All right, so here is the second part of our classifications and different types of injuries for the rest of the notes. So we left off with the tendon and muscle injuries, and so now we're going into the joint structures. When two bones come together to form a joint, we have either a ligament that connects a bone to a bone, or a joint capsule, which is kind of that balloon around it. And so that's what we're talking about when we talk about a sprain, an SP sprain. Different kinds of mechanisms. I like this one here. Basically, the joint gets forced beyond its motion that it can normally go. So if we talk about inversion ankle sprain, it can only go so far. Once we go farther than that, we start to damage tissue. The same kind of severity exists in that first, second, third degree. So we still have our micro, our partial, and our complete tear when we talk about first through third degree. But look at this right here. This is the key. It's that instability. When we talk about joints, we're talking about, is it a stable joint? And so when we start looking at the more severe injury, we have either no instability, a little bit of instability, and then that, if it's completely torn, we have an unstable portion of that joint. So that's the key, or that's the key difference on severity of sprains. So I put a couple of pictures. This one's really bad, obviously. As we go through here, signs and symptoms, the big thing you can stop this and write these all down if you need to. Definitely, we want to look at the next day is going to become a little bit worse. We want to try to get an x-ray. This possible neurologic symptoms is that numbness and tingling. It may happen right away. Hopefully that kind of dissipates pretty quickly. But if it continues, that's when we start to kind of worry a little bit more as we get through there. So the treatment, I mentioned getting an x-ray because we're talking about bone structures, right? And so if we have bones that are moving more than they should be, then we can have injury to the actual bone structure. So definitely want to get an x-ray. And then once we get through that normal 48 to 72 hour, that inflammatory phase that we'll talk about, that RICE, then we start getting into this stuff. Neuromuscular control is what this stands for. Mostly that has to do with stability exercises and balance. And so that's kind of the big things that we do from a rehabilitation side of things. We talk a little bit about taping and bracing. We're going to talk about taping in this class a little bit as a way to kind of prevent it. We did talk a little bit more detail in class, and that won't be as much on the quiz. We'll follow up as we get to our next class meeting. And then the other ones are just the simple strengthen the structures around it to again provide that stability, and then work on specific exercises for neuromuscular control, so balance and other stability exercises. Then we get into, we're still at a joint, but now we have that dislocation of a joint. And so there's two terms I need you to know. These are two important terms. You need to know what a luxation is. You need to know what a subluxation is. You can see them right there, complete dislocation, or the one that pops out and goes right back into place, usually pretty quickly. All right. So that's what we're talking about on the luxations. When we have a joint that is dislocated, when I ask you multiple pathology, in fact, highlight this, make sure you write this down, star this, do whatever you got to do. I'm going to ask you this, basically. I'm going to ask you what kinds of injuries occur with a luxation, subluxation. So because we're taking a joint and we're taking those two bones of a joint and dislocating them, everything around that joint, so ligaments, tendons, the bones itself, kind of rubbing on each other. And then look at this, nerves and blood vessels go across joints. So you can have injuries to all of those kind of things. Mechanisms, I'm not going to spend too much time other than usually it's some kind of a rotation and shearing is usually what the more common ones are. Again, if you don't like pictures, you better look away. I'll click through these on the video pretty quickly so you can see a couple more. That's a patella one, and then we have the this person is face down because his butt is up, and this This foot's right, this foot's not, right? So anyway, there we go. We'll keep going. All right, so as we get into the signs and symptoms, when you have a dislocated joint, the person knows something, something shifted, right? And so if it's still out, you definitely will have some kind of deformity comparing to the other side. The amount of function at that joint will be bad. It hurts. Here's that numbness and tingling from that nerve, at least being stretched, if not injured. And then the vascular impairment. If we take a pulse distal or beyond that, so if I dislocate my shoulder and I take my pulse down toward my wrist, I may not have a pulse. And that's kind of an emergent situation. We do not want that. All right. Shock, yeah, you can put that on there as well, because this is a very scary kind of situation to see your joint in a awkward position, right? So this question of reduce, we're not going to reduce. So reduce means we're going to put it back into place, especially if it's a luxation completely dislocated. For the general layperson, the guideline is do not relocate a dislocated joint. So don't reduce a joint. We're going to split it as is and get him to some kind of medical care to have that done. If you get this, if we have no pulse, or we do have that, we have a dislocation along with the neurologic symptoms, numbness, tingling, can't hear, can't feel anything. Those are concerns that we need to address pretty quickly, and that's why it's a 911 situation to make sure we're not doing that. All right, still at the joint. Right, so we got the bad ones at the joint. We've talked about. So this is still at the joint. This is bursitis. To know what a bursa is, we're like, so itis is that inflammation we talked about in tendonitis. Itis is inflammation. It's the bursa, and these are just like, think of these like little water balloons, right? So I got a little fluid sac, kind of like a little water balloon that's around the joints. Their whole job is to, is to reduce friction. So the mechanism for injury, right, is excess friction. So if we have too much friction, they can get inflamed. We can also have, so this is more of the chronic, this friction one is more of a chronic one, as opposed to the direct blow being a acute traumatic blow that ruptures the bursa. So just think about your water balloon rupturing, that kind of stuff, especially in this superficial. So here's another example of one. Here's your patellar tendon. On top of that, on top of your knee, there's this little bursa sac that's kind of helped to reduce the friction of the tendon going over the bone. And yeah, so if it can be ruptured pretty easily. You can see some of the contributing factors or risk factors for that. I got a good picture here. I'm going to put all this stuff up here. There's my good picture. This is probably a traumatic ruptured bursa, and so you can see how that just swells up real quick and then goes on there. So signs and symptoms. This is the acute one, right? So we might have excessive swelling if it's an acute ruptured bursa. If it's the more chronic friction-based kind of injury, then we have more of this aching all the time, definitely point tender, very, very similar to the tendonitis where it kind of hurts and then you get loosened up and it feels a little bit better and then gets worse again at the night, after you've been on it all day kind of thing. Definitely some similarities to tendonitis, except for this, right? If you're scoring at home, that aching all the time is the key factor. All right, this would be a similar, like if we had a ruptured bursa and it was this picture right here. Wow, it's all huge, and what happens to all that fluid? Well, it does this. It kind of disperses out along the leg and then gets taken up, and you get some nice bruising along the way. Treatment-wise, so for the most part, the acute version, if this was an acute version, we really just let the swelling go down and the person's returns pretty quickly. If it's the more chronic overuse time, then we do. If we have tight muscles, if we have overuse, if we have whatever we're causing it, we want to treat that and then look at some of the other common things that we use for kind of like a tendonitis along those lines. All right, the last couple injuries are with bones themselves. We have the stress fractures and normal fractures. So I'm going to put this up here. A lot of this is pretty straightforward. You can write these things down, and for the most part, the stress fractures are that too much too soon. The bone is just not strong enough for the stress that we're putting on it, and so we get a lot of pounding that occurs. The big thing I want you to pull from this part is, as we start to, you can see the contributing factors or risk factors that's going to increase the likelihood. Signs and symptoms, you can look. Here's what I want you to look at, this x-ray, but this little bullet point right there, you need to know that. All right, so it says 15 days before it really will show up on an x-ray. If I'm day 9 and my foot here has been bugging me because I'm a runner and I go get an x-ray, it's not gonna show it. It's because, man, your bone looks fine. Well, it doesn't feel fine, right? It hurts. So you might have to wait for that 2 weeks for this to show up on an x-ray. We already know, like day 9, if I'm running a lot and it's hurting right on my bone, I have a pretty good guess that it may be a stress reaction of some sort. This x-ray, you can see how nice and thin, nice and defined this bone is right here. That has that little gray fuzzy area is where it is. It's going to work. So this is a bone scan. So again, you can see kind of here, you don't have to wait for the 14 days for a bone scan. It costs a little bit more money, but you can see this is a normal tibia. These are normal bones. These should have nice and clear bones. That is an increase of activity that should not be there. So you can see some of those kind of things. All right, my phone's going off. I'm almost done. I'm going to put all these up so you can write these things down, especially on the bones. There's not, fractures or fractures. And so, yeah, that's pretty straightforward. Nothing I really want to emphasize on all this, but definitely needs to be referred and sent to some kind of a medical, either emergency room or a doctor to make sure that it doesn't need to be set or adjusted, and then it definitely is going to have some kind of immobilization. Don't worry about the specific timelines. This is not the class where I'm going to be picky on that. All right, so I've kind of hammered through those last couple topics there, injuries, and so I'm going to throw up a couple pictures here. If you don't like them, you can stop the video, and I'll throw, look at this right here. That's not pointed the right way. And then finally some, I guess, kind of, I was going to say fun pictures, but that doesn't look too fun. Really, that doesn't look too fun either. All right, that's it for, I'm not going to show you the video on this video, no video within a video. So hopefully this works.